If you are pregnant or you've recently had a baby, this podcast is for you. I am your host, Kath Bequee, a physiotherapist working in women's health and mum of 3 based in Melbourne, Australia. Join me as we dive into all things pelvic floor and core, as well as talking to different industry experts, helping you to have a healthy pregnancy, confident childbirth, and strong postnatal recovery. Hit subscribe. You're listening to the Fitness to Mama podcast. To attend my free pregnancy mini pelvic floor and core masterclass, head to fitnessmama.com/free. Well, hello there. Welcome back to another episode of the Fitness Mama podcast. This topic today is all about secondary infertility. We talk about miscarriage and pregnancy, and I'm chatting to Dr Raelia Lew from Women's Health Melbourne and Melbourne IVF. Dr Raelia Lew is one of the few Australian fertility specialists to have a CREI, which is one of the highest qualifications in reproductive endocrinology and fertility medicine. This means that Dr. Raelia Lew is highly qualified to help women, men, and couples overcome their fertility problems. Dr. Raelia Lew also has a podcast, the Knocked Up podcast, so do check that out, and I'll put all those links with how to connect with Dr. Raelia Lew in the show notes. So in this episode today, we are discussing secondary infertility and pregnancy after miscarriage. I trust this episode will be really valuable for those who are experiencing issues in this area. And it was brilliant to be able to chat to Dr. Raelia Lew. This is a really common issue that is historically not discussed about enough, in my opinion. So this is a really great follow-up episode to a few episodes back. I spoke to fertility life coach Robin Birkin. So if you haven't listened and if this topic does interest you, after today's episode, go back and find the 2-part series with Robin Birkin. Dr. Raelia Lew discusses the medical side of things, lifestyle, medical options when it comes to fertility. And then a few episodes ago, Robin Birkin, in the previous episodes, discusses more the emotional coping strategies that may be helpful during this time. So I trust you'll find today's episode really informative. It is value-packed, and I know you'll enjoy it if this topic is of interest to you. Before I do dive in, I do invite you to join us inside Fitness Mama. So if you have found you are not exercising as much as you'd like to during pregnancy or post-pregnancy, perhaps you're busy or you've lost the motivation to exercise, or you're not sure how to be best looking after your body. Or perhaps you've got pelvic girdle pain, abdominal muscle separation, and you're not quite sure about the best exercises for you. Or you'd like to get back into running after birth and you really want the best kickstarter for your after-birth recovery. Then Fitness Mama is for you. So join us for these convenient, short, easy workouts that you can do from the comfort of your home, whether or not that's at the end of a long day at work or when your bubba sleeps or whilst your toddler is running around causing havoc. So head to fitnessmama.com and the link is also in the show notes. Right, let's get into this episode. So, Raelia, thank you so much for joining me on the Fitness Mama podcast. It's great to have you back.
It's my absolute pleasure. Thank you for having me.
You're one of our first, only ever returning guests. So check out, ladies, we did a fantastic episode with Raelia in the early days of the podcast, and I will link it in the show notes. But in that episode, we talked about lubricant and we talked about all sorts of fun stuff. But today we are talking about secondary infertility and pregnancy after miscarriage. So thank you so much for joining me for this really important topic. Let's start. I know what you do, but can you explain to everyone, in case I haven't heard your first episode, what you do?
Sure. So my official title is reproductive endocrinologist and infertility subspecialist, and I'm also a qualified obstetrician and gynecologist. So in a nutshell, I'm a CREI qualified fertility specialist, and most of my bread and butter work of my daily practice is helping couples get pregnant. And I'm also the Director of Women's Health Melbourne, our practice in Melbourne, host along with Geordie Morrison of Knocked Up podcast, and also one of the directors of Lovers, which is a bespoke lubricant mark designed for women's pleasure.
Yes, amazing. And I'll put all those links in the show notes. Definitely check out the Knocked Up podcast. It's brilliant. So let's get started with secondary infertility, because as I was saying to you off air, we've just had, like at the time of recording, we've just had a beautiful life coach who she calls herself an infertility warrior, and she talked about the coping mechanisms and the emotions that can come with secondary infertility. And it's so great to be able to talk to you today about, I guess, the medical side of things. And yeah, so can you please start off, just what is secondary infertility?
So secondary infertility just means you've had a baby before and you're struggling to have another. You might have had more than one baby before and you're struggling to have a baby currently.
Yeah. And how common is it?
It's actually pretty common. And one of the major factors is age, because we're all having our first babies a little bit later in life now, and it becomes harder to get pregnant as we get older. So often when we try and have a baby, there are speed humps at any age. Most women who've had a baby will tell you they've had a positive pregnancy test that's gone negative and then had a period after thinking they were pregnant. That's called a biochemical pregnancy when it's confirmed on a blood test. And many, many women have had a miscarriage. I would say most mothers have had a miscarriage. And these events become more and more common as we get older, because eggs make mistakes more easily as we get older, and miscarriages become more common. So while when you're in your 20s, 1 in 5 pregnancies will miscarry, when you're in your 40s, at least 1 in 2 1 in 2 pregnancies will miscarry. And when you're over 43, it's even higher than that. So often secondary infertility can be associated with age.
Yeah, I didn't realise the stats were that high for over 40s. Yeah,
they are.
And in terms of the percentage of people that come see you, I'm really interested to know, like, roughly what percentage are coming to see you for their first pregnancy versus subsequent pregnancies?
Look, it goes both ways. Sometimes I help people have a first baby that's been a real uphill battle, and they'll have spontaneous subsequent pregnancies without needing assistance. And there's complex reasons behind that, but often we treat pathologies that are in the way, like, for example, endometriosis, through things like surgery, and then subsequent pregnancies can be sometimes easier, especially if they're close together. We can treat lifestyle factors. Obviously there's a lot less stress having a baby for the second time for many people, because they have the confidence that they've been able to have a child and they don't have that lingering stress that they'll never have a child. So, sometimes it's actually the opposite, and it's easier after the first time. And of course, pregnancy, I talk about pregnancy as the final stage of puberty, even though it's not necessarily, kind of a direct progression, but that's when our body matures from a reproductive sense. Our breasts undergo final maturation, our uterus undergoes final maturation, our endocrine system and our immune system have final adaptations to pregnancy during pregnancy. So sometimes we learn how to be pregnant by being pregnant. But there are couples who suffer secondary infertility. We've talked about age. There's also the fact that women, as we get older, acquire pathologies just because that's what happens to everyone. So things like fibroids, it's very rare to be born with, but they develop over time. Things like endometriosis might be mild initially and progress over time if it's untreated. You can acquire infections. Even after giving birth, you can acquire infections that can get in the way of a future pregnancy. You can have operations that cause scarring that get in the way of a future pregnancy. It's also important to understand that it's not just the woman, and that sometimes secondary infertility is of male origin. So men also make better sperm when they're younger than they do when they're older. And men also acquire pathologies as we get older. So they sometimes get a little bit more overweight. Sometimes they get varicose veins of the scrotum or cysts of the testis hydrocele. Sometimes just diet and lifestyle factors, things like alcohol, smoking can be detrimental to sperm and have cumulative effects over time. So the sperm can get worse over time. sometimes the aging egg can't cope as well with the burden of male factors. So the egg can compensate for poor sperm quality much better when it's younger than when it's older. So often it's a compound situation. And there are some also random genetic problems like chromosome translocations, which you can strike it lucky the first time and then subsequently have delayed a pregnancy or recurrent pregnancy loss related to that. And that can come from the male just as easily as it does from the female. So it's quite complicated, and it's important to recognise that secondary infertility isn't one thing, that every couple and every person is an individual with their individual problem sets. Often it's not just one problem but a compound situation, and there'll be within that modifiable and non-modifiable factors. So, for example, I can't modify your age, but I can modify your diet, and I can modify medical conditions that might be making it an uphill battle for you. So these are important facts to firstly investigate, identify, treat. Other problems that can make it harder to get pregnant are things like if your thyroid's out of balance, another problem that becomes more common as women get older. So looking at all your hormones, not just your reproductive hormones, looking at whether you're diabetic, because we know that women who are diabetic have more miscarriages. All of these things are important.
Yeah, and I love the fact that you did bring up the male counterpart, because I think naturally as women we just sort of go into ourselves and we're very good at guilting ourselves, don't you think? So it's really good that we do talk about the fact that it's not just us that might be a factor, it could also be the male. And out of interest, if let's say it's an alcohol issue maybe, how long does it take if they were to change their lifestyle with smoking and alcohol? How long does that take to help with the sperm quality?
So it will help after 3 months. So you really do need 3 months clean living, because that's how long it takes a bloke to make a sperm.
Yep.
So if you want to have a washout of bad behaviour, that's how long it takes. Obviously things like varicose veins and other surgical correction problems, it's a little bit different than that, because if you treat varicose veins, from the time that you treat surgically, there'll be a bit of inflammation around that healing time, and so that takes a bit longer sometimes.
Yeah.
But yeah, usually as a rule of thumb, it takes a bloke 3 months to make sperm woe to go. And that's how long we usually look between semen analyses in an ideal world. Sometimes we'll look a bit sooner just because of the practicalities of wanting to get a move onto treatment maybe, but no sooner than 6 weeks between 2 semen analyses if you want to see an impact.
Yeah, right. Interesting. Now, you've mentioned a few of the potential options for treatment. You've talked about lifestyle. You've talked about, potential surgery for endometriosis and that sort of thing. I'd love to know the medication side of things. What are some options there, like in terms of hormone treatment and all the rest?
So look, it really does depend on the individual. So what's right for one person may be wrong for another. So I really do say, there's no one-size-fits-all solution. You need to figure out what the issues are and the balance of those issues for that person. When we talk about assisted reproductive treatment, so IVF-related topics, that may be very targeted for different reasons. Like, for example, I'll give you a case scenario. I had a patient last year who subsequently had a baby through IVF. Now, she had 2 babies naturally without trouble, and then completely out of left field for her husband had absolutely no sperm on a sperm test in the ejaculate. So he had acquired a blockage. And what had happened is he'd had hernia surgery, and that had been either during the operation the spermatic kind of channels were snipped, or it could have been that they weren't snipped during the operation, but it might have been that the healing around the time of the surgery caused scarring that caused him to have a complete blockage that was acquired. And so for her, 1 cycle of IVF got her another baby, even though she was a bit older with a lower egg count, because she wasn't actually the issue. It was the fact that the sperm couldn't get to the egg. And once we took some testicular sperm, she made beautiful embryos. Whereas if you have a patient who egg quality is the main issue, then you can have multiple cycles of IVF and not get pregnant because you might not be making good embryos. So every person is different, and even two women at the same age are not identical.
Yeah, that's really interesting what you mentioned about what did you call it? The testicular extraction.
So azoospermia. Yeah, testicular sperm extraction. So if there is a blockage, which is called obstructive azoospermia, and that can happen after a vasectomy, for example, that you can't have any sperm in the ejaculate, what do? I take a fine needle and I take some sperm directly from the testis, and we can use that.
Interesting.
So there are ways around it.
And this is a bit of a side note, but does that, when you extract sperm, can that only be used for IVF purposes?
Yeah, that's right, because we don't get enough to use for anything else. So in natural conception, you need at least about 100,000 to 200,000 sperm at the egg interface for the egg to fertilise. Wow. So those sperm work like a team and dissolve the outer layers of the egg so that one can eventually get through. And one alone cannot do that. So it's like you're hitting your head against a brick wall. You need that kind of charging brigade to get through the brick wall. One's not going to get through. Yeah. The only way one sperm gets into one egg is with a needle to do that charge, and that's called ICSI. So, when you have sex and there's sperm in the vagina, 99.9% of the ejaculate is going to come out the other way, not going to go anywhere near an egg. It's only a tiny fraction that's going to actually move forward. So you need a really good count to compensate for that, because it's going to be a gradient and there's going to be a minority get to the finish line. So, that's why sometimes techniques like IUI, which is artificial insemination, or intrauterine insemination, can help, because what we do for a guy with a relatively lower sperm count is concentrate the best motile sperm, use the whole redundancy of what's in the ejaculate, not just what would reach the egg in nature, and deliver it closer to the egg so that we get a much higher concentration in the body. Now, with IUI, we have the opportunity to give what's called a bit of superovulation, which gives some drugs. It can be oral, it can be injectable. But what we're basically doing is trying to get the woman to ovulate a couple of eggs instead of just one. So just statistically improving her chances. And together with the male factor treatment and getting the timing perfect with monitoring on ultrasound and blood tests, that can increase what we call fecundability, or chance of getting pregnant per month, a bit. But it's nowhere near what we can do with something like IVF, because in IVF, what we can do is compensate for quality with numbers in women who are capable of that. So every woman's going to be different. You can have two women who are on paper demographically identical, graduated high school same year, went to university same year, same height, same BMI, different ovaries, right? Because just like you can have different bra sizes in that demographic, if you imagine that same scenario and have different bra sizes, one's a B cup, one's a double D, just like that, you can have one person with a high ovarian reserve or a low ovarian reserve, because one's got a bigger ovary and one's got a smaller ovary. So that's just genetic. Yeah. And so one woman can get 10 eggs in an egg collection, no worries. One woman can get 20 eggs in an egg collection, terrific. One woman can get 2 or 3, and that's all she can do, and that's just her. Yeah. And so every single person is different. And to talk to you about what your prognosis is in something like IVF, what we need to do is assess all of those aspects about you, because it doesn't matter, how the average woman of your age might perform. You're not average necessarily. We need to talk about you.
Okay. Well, you just took the words out of my mouth for the next question. That's exactly what I was going to ask is and I know you've just said it's hard to answer because everyone's different, but do you have any stats that you can share around prognosis? This episode is brought to you by Baby Bee, Australian-owned and designed prams combining quality, safety and style. Not only does Baby Bee let you try their prams at home with free returns for 9 months, yes, that's 9 months, they also offer an industry-leading 3-year warranty for total peace of mind. With thousands of 5-star reviews, around-the-clock customer care, and up to $300 of free accessories with every pram, what are you waiting for? Go visit www.babybeeonline.com and check them out for yourself. And yes, for listeners of the podcast, there is a 20% discount code. Enter FITBEE, FITBEE 20 at checkout, and T's and C's apply.
Well, look, it depends on your age. So yes, I do. If you are, in an IVF context, if you are under 30, every time I put a nice looking blastocyst, which is the type of embryo we like to transfer back, 1 in 2 is going to be pregnant from that. If you're 35, it's going to be more like 1 in 4, 1 in 3 to 1 in 4. You can't have half a baby. So, it's one of those stats that somewhere between 35 to 39 is, either 1 in 3 or 1 in 4 embryos makes a baby. If you're 40 to 42, it's going to be at the very most 1 in 5 embryos that makes a baby. And if you're over 42, it's going to be less than 1 in 10 embryos that makes a baby. And that's because we put an embryo back in IVF at a very, very early stage of life. It's got a lot of boxes to tick to get to being a baby. And it's just loaded with an increased risk of making a critical error as we get older. And the reason for that as women is we make all our eggs when we are babies ourselves in fetal life. So by the time you're 20 weeks and you've had your 20-week ultrasound when you're pregnant, if you're having a daughter, she's made all the eggs she'll ever have for the rest of her life. And all the eggs that might contribute to your future grandchildren are already there.
Isn't that incredible to think that?
It is. It's unbelievable, but it's also a real challenge with, the time frame of modern life. Because if you were, for example, imagine a world before contraception, imagine a world out in the jungle, we're cave people, right? You're going to have babies when you're a teenager for the first time. Probably not going to live beyond your 30s in realistic terms. That's what our life expectancy was back then. That's what we're biologically designed to do.
Yeah.
And it hasn't been that long in an evolutionary sense since that's what we were made for, and so we've changed the way we behave radically, even in 2 generations. If you think about when your grandma was having babies, likely if she was mid-20s, she was probably, kind of tapped on the shoulder by a parent, said, listen, love, you're going to be an old maid. That's just the way. I know that's not necessarily politically correct to say, but, that's what happened in that generation. Our mothers pushed the boundaries a little bit, and kind of, probably in the 70s and 80s, the average age of first baby was more like 25 compared to their mothers' generations where it was more like 20.
Yeah.
And in our generation, the average age of first baby is about 33 right now.
Is it really?
And when you think about average, it is. And when you think about averages, 50% of people are spread around the mean. It means 50% of women are taking longer than average to have their first child. So it's no surprise from a biological perspective that secondary infertility is becoming more and more common because we're having babies at the age where in the natural world our babies would be having.
And that's why we're just so lucky that we have medical technology and, this has enabled us to have this choice in our life whether or not we do have babies. So, yeah, it's brilliant. Thank you for sharing.
Yeah, look, some people it's a choice, some people it isn't a choice. Some people technology won't save the day, and that's really important to acknowledge. IVF's not a silver bullet. I can't help everybody with their own egg. It's one of those things that if eggs are not able to make babies anymore, I can still help you have a baby, but you'll need a donor egg. And you can have a donor egg from somebody younger whose eggs are still fertile. And many people do choose to do that. And you know what? We need to destigmatise that given the way that our society is going. And we also need to destigmatise egg freezing because that's something younger women can do to create a resource for themselves that they can use later if they need it so that they're, quote unquote, their own donor. So you can use those younger eggs. Yeah, you'd have the same prognosis with, say, a 30-year-old egg as a 30-year-old woman. Even if you use that 30-year-old egg when you're 40.
Yeah, amazing. And I have heard in the last few years a lot more people are freezing their eggs, which is brilliant. So
yeah,
if someone's listening and suddenly thinking, oh, maybe I need to investigate this, what's the first step to investigate freezing eggs?
So, look, I would always say the first step is go along to your GP because to see a specialist, you need a GP referral. You don't necessarily need one, but it's easier under Medicare in Australia if you have one because you're entitled to a Medicare rebate with a GP referral. And your GP can also give you some initial information and organise some initial investigations. So things like, and this goes for infertility as well. If you're over 35, it's been more than 6 months, and you're worried that you've got secondary infertility or primary infertility for that matter, go along to your GP. There are some baseline tests that can be very helpful. Remember, it takes two to tango. Your partner should have a semen analysis as a bare minimum, and he might require other tests depending on what that shows. But for yourself, you can have a pelvic ultrasound, you can have routine antenatal screening tests, including a baseline hormone assessment to see what's happening with your cycles and with your hormones. And I'm not just talking about your menstrual cycle hormones, but also your global hormones. You can have a checkup of your sugars and your cholesterols. So all of those investigations are helpful. You can have a pelvic ultrasound to see if there's an anatomical concern, and there can be quite commonly anatomical concerns that are really easy to treat, like a polyp, for example, which can be removed quite simply with a minor procedure. So, there are things to discover, and often when I see patients, I also offer them the opportunity to have their fallopian tubes flushed with contrast imaging, because that can help me, A, understand if they're working or if they're blocked. And they can become blocked through different mechanisms. So one is through inflammation and scarring, and endometriosis is a very serious culprit when it comes to that, as are pelvic infections like chlamydia, gonorrhea, and infections that you can have after having a baby like endometritis. But also you can have a blockage that's functional. So you can have a blockage with mucus plug or skin cell buildup that can actually be cleared by flushing, and that can help you get pregnant. But I decide who gets a tubal flush by ultrasound compared to who gets a tubal flush at laparoscopy, which is when we do a keyhole surgery and a really classical investigation of the pelvis surgically, based on that first pelvic ultrasound, which tells me, are there likely pathologies there that we would need to co-treat at the same time, or am I suspicious of serious endometriosis? So we kind of use that first ultrasound to check out, well, hey, what's going on in the pelvis? And then in terms of flushing the tubes, we can decide whether we do that through imaging in a less invasive form, or whether we do the whole shebang in one procedure to try and fix everything, depending if we find other problems on the scan.
Yeah. So
those are the kind of issues with fallopian tubal patency. If your tubes are blocked, you can't get pregnant.
Yeah.
So that's important. Some women have had an ectopic pregnancy in a tube before that was managed without removing the tube, and that can cause scarring and blockage and an increased risk of A, secondary infertility, and B, future ectopic. So that's also part of some people's backstory.
Yeah, okay, interesting. And if someone's listening today and they've had a previous miscarriage and they're wanting to get pregnant again, at what stage, at what stage should they seek help? Or is there anything they need to do after the miscarriage to help with a future pregnancy?
Sure. So let's talk about, firstly, just setting the scene for what I'm going to say next, monthly fecundity. So that's your chance of getting pregnant per month. So statistically, we talked about when you're 20, your chance of getting pregnant per month is about 1 in 5. When you're 40, it's about 1 in 20. And in between, it kind of goes down. So we know that 80% of couples who are going to conceive will get pregnant in the first 6 months trying. So, if you've tried for more than 6 months and you're over 35 for any reason, whether it's related to a miscarriage or not, it's very relevant to check out all the modifiable factors and try and seek help, because, time is the biggest contender and it's your biggest risk. So really we want to fix things that can be fixed quickly. So it's not necessarily about put your foot on the pedal straight to IVF, but it's about, trying not to waste time, which is your most precious asset as a woman over 35, in terms of your prognosis for actually successfully being pregnant again. In terms of, miscarriage is a broad kind of term. It can refer to, kind of having a period that's a week late and not having any ultrasound signs of pregnancy, or it can refer to losing a baby at 19 weeks. So obviously those two scenarios are extremely different. There's also mental health aspects that are, obviously some people feel really shattered by losing a pregnancy, even if it was a faint line on a P test and then disappears. So when you're ready to try again emotionally is obviously very different, and I'm not talking about that right now. I'm talking more about when you're ready physically. When you're ready physically is when you have your next natural cycle. You don't have to delay trying. It's an urban myth that you have an increased risk or a decreased risk of getting pregnant in the months after a pregnancy. That's simply not true. So, you can try again as soon as you want to, as soon as you're ready to, and as soon as you ovulate again. Some women do have a delay to ovulation returning, and that's because the HCG hormone in our bloodstream has quite a long half-life, and it can take a bit of time to get out of our system, and it's only when it does get out of our system that we're going to really ovulate again, most likely. But also some women have extreme stress, and that can also delay their ovulation. So, it's one of those things that it can be variable when your period comes back after a miscarriage, and that's okay.
Yeah, okay. Thank you for sharing. You've been a wealth of information. We have dived into a lot of things here, so thank you. To finish up with, do you have any final pieces of advice, words of wisdom to women who are listening today who are either pregnant or trying to conceive?
Yeah, look, I think one thing we haven't talked about is recurrent miscarriage for medical reasons. So there are some people who have developed a syndrome called antiphospholipid syndrome, where they have an autoimmune cause of recurrent miscarriage related to blood clotting problems around forming a normal placenta. It's really important to recognise women with that problem. It's also really important to recognise women with other issues that can cause recurrent miscarriages, like fibroids inside the uterine lining that need to be removed, because otherwise they might have miscarriage after miscarriage after miscarriage. So, it's hard to, in general practice, and also I guess it's so hard for women to realise that miscarriage, when it's a pathology that's underlying that needs further investigation, and when it's an unfortunate fact of life because of advancing age or a baby making a mistake. We know that in 50% of miscarriages, it's a baby making a mistake, nothing to do with the mother. So attributing blame to yourself in that situation, it doesn't make any logical sense. It's a baby that made a mistake, and no matter what you did, it wasn't going to end differently. So things like chromosomal random error.
Okay. Yeah.
But then there are some factors that we can address, and we have to identify them. So things like luteal phase deficiency, where as we get older, we don't make as abundant a supply of progesterone. It's not necessarily something that happens every cycle. Not every corpus luteum, which is the ovulating follicle resultant progesterone making factory on the ovary for early pregnancy support, not every corpus luteum is equal. Not every corpus luteum is going to be as functional or as good as every other. So you can have a luteal phase defect in a particular pregnancy or a particular cycle as opposed to in general. But for some women, supplementing progesterone in the luteal phase can help. And I certainly do that a lot in my assisted reproductive treatment practice. All my patients having IVF get luteal phase support. All my patients having IUI get luteal phase support as a belt and braces approach. I would say my take-home message is every woman is different, every couple is different, every situation is different. The recommendation for investigation of recurrent miscarriage is after 3 consecutive losses. It sounds incredibly harsh, but that's because miscarriage is incredibly common, and most of the time we don't find an issue if we investigate thoroughly after 1 or 2 miscarriages. But, if you are older, if you are, feeling time pressure, come and see a fertility specialist and have a thorough workup. We don't have to wait for you having 3 consecutive losses to do that, and it might give you reassurance, and it also might just highlight other pathways, alternative treatment methods that might come under your radar that you might want to pursue.
Amazing. Thank you for all that information.
You're very welcome.
It's a really important topic to discuss, which I think historically we haven't spoken about as much. So I do appreciate taking your time out of your holiday and chatting. So thank you.
You're very welcome. Anytime.
We'll chat to you soon. And before I sign off, remember my team and I will be putting together the show notes for this episode with all the links, including how to connect with Dr Raelia Lew and myself at fitnessmama.com/podcast. Have a fabulous day, everyone, and I look forward to you joining me next week for another episode of the Fitness Mama Podcast. Thanks so much for listening to the Fitness Mama Podcast, brought to you by my free pregnancy mini pelvic floor and core masterclass, which you will find at fitnessmama.com/free. Be sure to subscribe so you don't miss an episode. And come and say hi. DM me on Instagram. I would love to hear from you. It's at Fitness Mama. Until next time, remember, a healthy pregnancy, confident birth, and strong after-birth recovery is something that you deserve. Remember our disclaimer. Materials and contents in this podcast are intended as general information only and shouldn't substitute medical advice, diagnosis, and treatment. I'll see you soon.